So, if I'm not wrong, this is the last session for today. And it's about a 20-year anniversary from adoption of DES to clinical practice after RAVEL. RAVEL is the name of a study. So I will moderate this session, and I'm very happy to have this kind of historical session, to have Guy Hendricks there. And Guy will present the history of DES development. 20 minutes, Guy?
So I realize that when organizers are asking you to talk about the history of something, that you mustn't be very young anymore. But so be it. So I took the bird's-eye view to talk about the history of the 20 years of DES development rather than a road trip from trial to trial in order to avoid getting entangled in the web of statistics and figures and numbers and protocols. So we were just reminded that each device, and especially stent is a device, goes through a development cycle when it's introduced. And it starts off with numerous iterations because we need to chase the evidence that the new device works. Very soon we got faced with the disease substitution, the heterogeneous effects of the device. The whole process spins off new knowledge, and probably the new device will disrupt regular practice as well. And since devices usually need drug as assistant, there is always the love and hate affair with drugs as well. And of course you have the end of the cycle for medical reasons, for technical reasons, for regulatory reasons, for economic reasons, as was brachytherapy as an example, and then starts a new cycle. So let's take the coronary stenting as a case example of this cycle. So we remember that the immediate results of POBA were very poor, with unacceptable high recurrence rates, up to 40%, mostly within 3 to 6 months. And we learned very soon that this was due to passive recall, barotrauma, and release of mitogenic factors. So the constrictive remodeling was identified by IVUS. And of course, restenosis was viewed as a new disease at that time. So solutions, well, the first solution was pharmacological strategy. And there was indeed an economic pressure to find agents or combinations of agents to prevent restenosis. Several avenues were followed, the platelet receptor and mediator inhibitors. As an example, the thromboxane A2 receptor antagonist. Then there was the smooth muscle cell proliferation inhibition, angiotensin II receptor inhibitors, and then the growth factor inhibitors, angiopeptide. Now it's clear, a lot of resources were put into clinical trials to find a pharmacological way to prevent restenosis. But this strategy failed. And probably one of the major reasons why this strategy failed is that the preclinical models used were probably wrong at the start. A lot of research was done in rodents, in rats, and also in rabbits, in other small animals. Also different arteries were used, aorta to put in lesions, or iliac arteries. And it's clear that the wrong preclinical model was probably the reason why jumping to the patient didn't work. And this reminds me of a quote from Robert Rushman, who said that experimental data are applicable only for those specific conditions in which they were obtained. And of course, in the industry, they tend to cut corners in order to advance quick to get the product into clinical practice. But this is a typical example why choosing the wrong preclinical animals to study the process of restenosis did fail. So the second solution to restenosis was, of course, metallic scaffolds, because they achieve a better initial results. They were tagging the tears and prevention of late shrinkage. And if you look at the corneal stent acronym, it started off with bare metal stents. Then we got the first generation eluting stents, the second generation eluting stents, and then as a sideway, a few words about the bare metal stents with bioactive coating, and then finally the bioerodible scaffold. So bare metal stents, people here may forget that we worked at least 10 years without having stents on board, from 1977 to 1987. We even didn't get guide wires, so that was a tough period. Now, the first substituted disease for the bare metal stent was the early stent thrombosis. And of course, this could have been expected because, as Virchow told us in 1856, the triad and the interaction, which was propensity for thrombosis, was either local vessel wall substrate, changes in rheology, and changes in blood composition. And with PCI, we damaged the cell wall. There was endothelial damage, endothelial dysfunction. Of course, there was this foreign material, metal alloys, polymers, all suitable to interact with changes in abnormal blood flow and rheology, change in shear stress of the endothelium level, and then also change in the blood components with platelet adhesion, platelet activation, and aggregation. So this triad was just the ideal substrate to get thrombosis. So we very early on identified mechanical factors which tended to promote stent thrombosis, like underexpansion, edge dissection, incomplete coverage of the stent, and stent malapposition. And this was probably the reason why IVUS-guided PCI was at a certain time very popular. I show you a few examples. On the top, you have a dissection, exit dissection of a stent. Next, we have the malapposition or an uncovered stent. And the middle row shows us neoatherosclerosis with rupture. And the bottom example is a clearly underexpanded stent. So, the solution for the early stent thrombosis was the obligatory systemic dual antiplatelet therapy for at least 2 months, and with success. I just remind you that previous strategies were tried also, and imagine aspirin and warfarin at a certain time were popular, so imagine that you have retrieved a sheet under warfarin. But it's been clear that once the combination of aspirin and ticlopidine at that time and later clopidogrel were found, these first problems were taken care of. Now, the substituted disease number 2 was, of course, a stimulation of the neo-intimal proliferation or the instant restenosis with a recurrence rate less than 20%, which is already half what it was with bare metal stents. So this intimal proliferation has been nicely documented. This is imaged immediately post-angioplasty. Then you have the dissection and the intraparietal hemorrhage, and the stent covers of scaffolds the wall and prevents shrinkage and of course 4 months later you have the full blown picture of massive restenosis, which you also see in autopsy material. So the solution here was either to go for cytotoxic or cytostatic therapies, and in fact radiation therapy, especially the brachytherapy, was successful at a certain point in time, but this was recalled by the company just for economic reasons. Besides radiation therapy, we had then the drug-eluting therapy with a certainly decrease in the recurrence of restenosis to less than 10%, which was another big step forward. So the key objective of those cytostatic and cytotherapies were the inhibition of neo-intimal proliferation. So the accent was on the late loss, and as an example here, with the BMS, the late loss, lumen late loss was in this example 60%, and with the drug-eluting stent, the late lumen loss was reduced to only 10%. And it's clear that if you look at the distribution of late loss, there was a strong correlation between the late loss and the anti-proliferative potency of the drugs or the radiation, whatever. So the first generation of drug-eluting stents were spectacular, and you will hear more by Louvain about the RAVEL trial, but I just mentioned you the 6 months result of the RAVEL trial, which was sirolimus eluting stent. Sirolimus, an anti-proliferative agent with a powerful immunosuppressive properties. And it's very surprising to see that after 6 months there was almost an identical cumulative stenosis frequency curve as immediately after the stenting. And of course the late results and the Kaplan-Meier on event-free survival was also very impressive, with more than 94% event-free. Oops, we're here. So the second trial on the other side of the Atlantic was the use of the paclitaxel eluting drug. Taxus inhibits cell division, motility, and also signal transduction. And the results here at 9 months were also very comparable as the RAVEL trial, with only a small shift of this cumulative distribution of the percent stenosis diameter. Looking that further down the road, the long-term results of the RAVEL were still positive compared to bare metal stent. We see that there was, of course, still incidence of restenosis and stent thrombosis. So the next substituted disease was the late and the very late stent thrombosis with drug-eluting stents. And this came, in fact, as a surprise when it was shown that even after several months or after several years, there was a steady progression of events related to stent thrombosis with the sirolimus eluting stent as well as with the paclitaxel eluting stents. Also, a very specific eosinophilic arteritis has been described, and it's clear that from those specimens analyzed and colored with hematoxylin and eosin and with other stains that are typical for eosinophilic granules, it was clearly shown that this was a delayed hypersensitive reaction to stenting associated with remodeling of the artery wall. So the solution for this late stent thrombosis was obligatory systemic dual APT therapy for more than 12 months, and of course the search for second generation of stents with new device, polymer drug interaction, thin struts, new metal alloys, biocompatible and or bioerodible polymers, and also drug targeting the mTOR cycle, cell cycle mechanism, as you have just heard from Boston Scientific. So the second generation stents were available, and one of the first trials comparing a first generation stent with a second generation stent was the Spirit 4 trial, in which it was clear that at 1 year, still not a very long follow-up, there was a 38% reduction in the target lesion failure, and also a 45% reduction in ischemia-driven target lesion revascularization. And at the same time, mortality as well as stent thrombosis was significantly decreased. Now, the follow-up was only 1 year, so we needed, since late stent thrombosis occur late, they don't occur very frequently, but they do occur, and in order to see if we can prevent those late stent thrombosis, longer follow-ups needed, and the PROTECT trial was ideally designed to answer that question with at least 3-4 year follow-up, comparing again a second generation stent, the Endeavour, with the Cypher stent. And if you look at the primary endpoint, it is clear that although in the initial phases there were some numerical higher values for the sotavolimus for the second generation stent, up to 3 years there was not much big difference, but after 3 years became a separation of the curves with less incidence of probably and definitely stent thrombosis. And at the same time also global mortality on the left and cardiac mortality on the right were also less with the second generation drug-eluting stents, and this for a period of more than 4 years. Also, mechanical factors have been isolated or described which will promote late or very late stent thrombosis, uncovered stent, neoatherosclerosis, coronary avulsionation, stent fracture, and malapposition are all factors which may stimulate or be responsible for late stent thrombosis. So just a parenthesis about bare metal stent, the bioactive coatings. Contemporary stents are made mostly of stainless steel, of cobalt chromium, which all comprise nickel, cobalt, and even molybdenum. And we know that 15% of the population is allergic to nickel and cobalt and even to molybdenum. And this may be a factor for inflammation, and it's been shown experimentally that these elements, these metal elements, are inflammation promotion. And so the design of this stent, of this trial, was to compare the titanium stent, which is a titanium nitrate oxide coated stent, was a bioactive stent, compared to a Zions everolimus eluting stent, a second generation stent. Follow-up for up to 7 years, which is remarkable, and it's very impressive that after 7 years, the bioactive bare metal stent didn't show statistical non-inferiority, which is a remarkable. Of course, the design had some limitations, but in fact, the results are there. So finally, the bioerodible scaffold introduced in 2012, meant to be a temporary stent, only need during a couple of weeks or months, and then disappears by itself. That would be the magic bullet. The first stents were made of polyl lactide, and just metabolically was in hydrolysis of the PLLA, and finally the mass would disintegrate in CO2 and water. And the phenomenon is real, as has been shown from OCT pictures. Of course, the great tragedy of science is that the slaying of a beautiful hypothesis is usually by an ugly fact. And the ugly fact here was the 5-year outcome of the ABSORB trial, in which it was clear that the primary endpoint, the target lesion failure, was still 3% higher than compared to the second generation stent, and therefore the stent was also recalled. So this is a short, I think I will stop here because I'm used up my time. I think this is a short bird's eye view of this evolution, where I just marked a few key points during this evolution and ended up where we stand now. And I'm sure on the bioabsorber stent there is certainly a new chapter to be written with the magnesium component as well. Thank you.
Question or comments?
Small comment is, apart from just the development and the evolution of stents, is our understanding of how to deploy stents. Like initially, we started by doing high pressure inflations, previously nominal pressure. And then further evolution is the fact that we know that lesion preparation is very important. So I know you mentioned stents, but perhaps along with that came these two factors too. Thank you.
Yeah. Thank you, Guy. So can you introduce me?
Professor Luvar is going to talk about interventional cardiology pre and post era. Please.
So I will present, was asked to present RAVEL, 20 years anniversary from adoption of DES to clinical practice after interventional cardiology, pre and post era. I mean, they asked me to speak before RAVEL and after RAVEL. And I'll try to avoid that because first I will overlap with the talk of Guy Hendricks. And second, I think will take hours. So this is, I will present also my feeling during this long time period of my career. And the fact that at the beginning I was passionate by interventional cardiology, but not yet by clinical research. I was taught for this by Marie-Claude Maurice, I will tell you later. So here for the young people here, at the top left you have Andreas Grunzig. He was, you know, working with a lot of passion. I've never seen him in person because he died for a flight accident. He was piloting the plane. A few years after moving from Zurich to Atlanta in US. He was coming back from Virgin Island to Atlanta, if I'm right. Top right is the designing of his first balloon. It was in his kitchen, if the comment is true. In C, you see the first coronary angioplasty in human. And this is a proximal LED lesion, C, and D, you have the follow-up, the result of the follow-up. And the bottom left, you have Ulrich Schirgwart, and just close to him, Jacques Puel. So in France, we say that Jacques Puel was the first to implant self-expanding wall stent, self-expanding stent in a human. And of course, in Switzerland, they say this was Ulrich Schirgwart. But it was between end of March and beginning of April in 2006. At that time, first I will go back on my trajectory. I did my first puncture of the femoral artery in 1979. It was for coronary angiography, and quickly I heard. I was not, of course, I was a young fellow when Andreas Grunzig presented his paper in 77, I think, AHA. And but quickly after my first puncture, I heard and I saw the papers, and I was thinking I will go on with interventional cardiology, not only diagnosis. I did my first balloon angioplasty on the 16th of September 1983, and 16th of September is the day when 6 years earlier Andreas Grunzig was doing his first balloon angioplasty. Oh, sorry. After that, I had a chance to. I was working with balloon angioplasty, as said by Dr. Hendricks, for 10 years, and as the first stent was implanted in 2006, my stent was implanted in January 1990. And it was a very special stent I will show you. And at that time in France, and I think it was exclusive to France at that time, in 1989, Paul Barragan, working in Marseille, a colleague in France, proposed to replace a complex association of heparin, dextran, coumadin, and many other things, to replace this heparin for a long time by diclopidine. So introduce an antiplatelet treatment is an anti-thrombotic thrombotic scenario. So this was the publication of Paul Barragan, was published in 1989. It was about 387 patients, so it was quite big. And it gave an idea in a group of interventional cardiology of the French Society of Cardiology, an idea of Paul Barragan and of Marie-Claude Maurice, I will present her later, to begin a special study. It's not a randomized trial, and it was criticized. It's a big registry in France, up to 3,000 patients, with a introducing progressive reduction of treatment after stenting. So if you know the progression, the first period was the patient has received 200 milligram aspirin during the procedure, then 100 milligram for 1 month, and diclopidine 250 milligrams for less than 80 kilograms, up to two pills for bigger people. After the stenting for one month. After that, the heparin was associated in this cocktail and was followed by coumadine. And first, we suppress the phase 2 after schist withdrawal, continuous heparin for 48 hours, so it was a bit less long. Then low molecular weight heparin, which was another improvement. The third one, phase 3, was low molecular weight heparin for 2 weeks. After that, phase 4, no post-procedural IV heparin, low molecular weight heparin for 1 week. And the phase 5 was suppression of low molecular weight heparin. So the patient received then heparin during the procedure. After that, diclopidine and aspirin. And looking at the event there in hospital stay, at the event, you see in dark line the hospital stay. And of course it was reduced. After that, the dotted one is, sorry, I don't see very well. This is a complication rate. And after that, the 2 is stent-related cardiac events, which was stable, slightly moving up. So in 1995, this paper was published. But I entered this study in 92, take 3 years, and was published. And in France, nearly all the centers moved to this practice. And to have a trial, randomized trial, in comparing the two strategies, in France, we have to wait. Michel Bertrand was in 1999 or something like this. So I think was important at that time to promote the stent in France. And a second aspect, also related to my practice, was to reduce the rate. We still have vascular complication. They were reduced but not suppressed. And second way to reduce the rate of vascular complication, I remember my boss was nearly asking me to stop stenting because we had 3% of femoral surgery. So in November 1993, I moved to Ferdinand Kemeney lab in Netherlands to learn the radial approach. And I was the first to do the radial approach in France for PCI in January 1994. And what I'm showing here is much later, 2013, 2015, all the operators of our group, you can see that we are nearly all higher than, at that time, we are nearly all 90%, all higher than 90% for PCI, and also more than 90% for coronary angiography. And it changed the radial approach, changed everything. The vascular surgery disappeared. We had some hematomas that we learned how to work with. And it was a real change that pushed again the practice of stenting. I was the first, but I was followed quickly by Christian Spalding, Thierry Lefebvre. We were not yet in the same group at that time. And very quickly in France, France became the biggest country for the radial approach. The stent I put 1st of January, in January 1990 is Palmachat Johnson & Johnson, PS 153. This is, for me, this is a bit emotional. You see, it's a piece of metal with very rustic, with two pieces with a bridge in the middle. The bridge is 1 millimeter long, and very quickly we learn how to stent two lesions in the same patient with such two short lesions in the same patient with this stent, because we were cutting the bridge, removing completely, and we were using for two lesions in the same patient, or even for two different patients in the same day. And so the association of this rustic Palmachat stent, the cyclopidine, and the radial approach make very popular the stenting in France, and we received after that other stents. I won't develop this. RAVEL. RAVEL, the study began in 1999. It was led by Marie-Claude Maurice, and in 95, so just after the radial introduction, Marie-Claude Maurice quit his place in northern part of Paris to go to southern part of Paris, asked my friend, brother nearly, Thierry Lefebvre to come, Pierre Dumas to come, and myself to come to build the group we are, Massy Group, ICPS, Institut Cardiovasculaire Paris Sud. And we went together to work in Massy, in 3 centers, in fact. And after that, I was initiated by Marie-Claude to a clinical research, and was my first, not among the authors, but my participation in such a big trial was something very new for me, and began in 1999. This trial is a randomized double-blind study, double-blind. So the stent we put in the patient, we didn't know if it was a sirolimus or no sirolimus. They were exactly the same. So it was absolutely no bias. You will see. We discovered how different was the result. I will show you later. So comparison of BX velocity with sirolimus and the balloon without sirolimus. You can see many other famous operators there. So it was European, mainly European, but not only. Brazil, you will see on the next slide that they included a lot of patients. So it was in Europe, 6 centers in France. We were ready to receive this trial, 1 in Belgium, and 2 in Netherlands, and 3 in Italy, and the other one were in Brazil. As you can see, they included the most important number of patients. And on the left, you have thorax centrum and Massy at the same level, 25 patients in each group. So recruitment was completed in December 2000. The endpoint was scheduled at 6 months. So it was at the end of June 2001. The 12 months clinical follow-up was ended at December 2001. And the end of the study at 3 years was in December 2005. So the primary objective was to measure the safety and effectiveness of a sirolimus-eluting, drug-eluting BX velocity stent. And at the angiographic follow-up at 6 months, first endpoint at MACE endpoint at 1 year, but the real endpoint was at 3 years. Oh, sorry. No, what I'm doing? Oh. Ah, no, it's not the good button. Sorry. There's a problem when you are old like me, so I need normal glasses, but just to see here. So, these are the QCA instant analysis, and this is the phenomenon. Here is a slide. You will see on the next one how it is. The lead loss at 6 months was minus 0.01. So it was, in fact, a slight positive growing of the lumen, compared with a lead loss of 0.8, which is enormous. And the restenosis rate was 0 in the group of Cypher and 26% in the control group. Of course, it was not necessary for us to communicate with CRO to know which one was sirolimus and which was not. This is the difference. So this is the treatment here of the patient on the left before, LED lesion with a small diagonal. Big diagonal was forbidden, but small one was just protected. And the result on the right. And now we spend a bit of time on this one. Look at this. This is sirolimus. You know, the two pictures are completely identical. And only one difference is on the left is on the so-called old cath lab with dispersion of X-ray like this. And the right one is the flat panels. It occurred at that time in 2000. And you can see that you can look, you know, immediately we know that the patient you are controlling was in the sirolimus group. Remember this. Guy Hendricks has shown this slide, and which was used in most of the trial for evaluating the new stents. And you can see on the left here, 3 lines are superimposed. It means that there is no difference between the end of the procedure and the follow-up. 2 follow-ups, maybe. So the MACE at 6 months was also, of course, followed by the same result. No difference in mortality, no difference in Q wave and non-Q wave. And the TLR was 0 on one side and 26% on the other side. 26% versus 0. 26 was what we were living at the end of the 90s with many stents we have at that time. And with balloon, as was said by Guy, was between 40 and 60% restenosis. Enfin, progression. And very few MACE, 96.7 no MACE, and opposite on this, 72.9. So a great, big, spectacular clinical endpoint. So this is this is a curve showing exactly the same. So it's very clear to see where is the success. So conclusion, a bit enthusiastic. I would say probably proposed by Patrick Serrois. He likes this kind of things. Abolition of neo-intimal hyperplasia is clinically translated abolition of neo-intimal hyperplasia. Imagine. And of course, immediately after this was because it was presented in AHA, I think. So immediately after that, ASC. Immediately after that, Wall Street Journal saying that we have a solution for any lesion in the coronary arteries. The same in New York Times, and you can imagine that the money, the amount of money that came to this to this company. This is a paper presented by, published by Michael Morris in New England Journal of Medicine. I'm not on it, so I'm only. Again, this is signed, Patrick Serrais, which is the RAVEL trial, 0% restenosis, a cardiologist's dreams comes true, signed by Evelyne Réagard and Patrick Serrais. The long term was 3 years, was shown already by Guy, so was like this, still in favor of a cipher. And we have a revascularization rate still really different, but some attrition. And it was, cipher was followed by other trials, the US one, much bigger, 1,100 patients. And after that, we were in, with this slightly different result, with some TLR and at 9 months, some TLR at 1 year and 2 years in the group of cipher. The curve. And we were invited, Sirius invited Europe to come in this trial with 350 patients, invited also the Canadians, that was C-Sirius. So E-Sirius, C-Sirius, and future studies are here. ARTS, instant restenosis pivotal, bifurcation pivotal study, saphenous vein graft feasibility, CTO feasibility, left main. So the program was big. And this is sirolimus bifurcation. I was working in it, and I am among the authors of the paper. I was with these 3 centers, but this was the rate of protocol violation was enormous. I think it was 23%, supposed to be a single stenting versus double, and crossing not to a reasonable session, reasonable technique like T at that time, but moving to the crush technique was the beginning of the crush technique. So 2006, suddenly, occurred was some people called the firestorm, what in World Congress and ESC Congress, at the same time in Barcelona, occurred the presentation of Eduardo Kamenzin. He was working at Geneva, and the paper was co-signed by Philippe Steg, a French Parisian colleagues, friend, and William Wines. And what is a presentation, meta-analysis, in fact, of RAVEL, Sirius, E-Sirius, and C-Sirius. What this presentation showed? She showed the endpoint there is death and QAVMI. Was not a predefined endpoint. The endpoint was death alone or MI alone and MACE. But okay, maybe we say in France a bit of bricolage. You know, they put some death and QAVMI. And death and QAVMI, there is a difference, which is at least a strong trend at 3 years. This is the presentation in Barcelona. And here you have incidence of serious adverse events, death and MI. It showed the difference between what occurred with ACS. You see now this is P003, death, serious adverse events. So this is what they showed. It was related to sirolimus, but not to Taxus on the right. Taxol, sorry. After that was real storm, yes. In Europe and Japan, the reaction was moderate. As you can see, Japan was very high, already 70% at that time. But in Europe, went a bit down slowly and remained and went up later. But in US, you see that ESC conference, and you see immediately after that, you see the fall from 80% to 60%. So a big fall. And I presume that in stock, not only I presume, but I'm sure in stock exchange in New York was exactly the same. And they have in US, they wait a long time to went up, was in 2008 before moving up again. So the paper of this presentation in Barcelona by Kamenzin, here is here. This is, he has not the format of, the paper we see normally. And these are the results, showing a death, all death QMI, not difference, QMI 0.006, not difference, but death and all QMI, death all and QMI 0.003. And here included in this paper was, I think this is the most important part maybe of my talk, is an answer by Patrick Sorais. So I will read what is underlined. The risk of death, myocardial infarction and stent thrombosis is higher when drug-eluting stents are used off-label as compared with on-label usage. And the second sentence is just bottom. Cause of contact concluded that long-term monitoring of safety outcome, including device traceability, should be mandated by regulatory agency whenever a device is allowed for clinical use, and that is of particular importance that adjudication of events, data monitoring, management, and analysis, as well as long-term follow-up, be performed independently from sponsoring device companies. So was very clearly facing the work of CRO and the way that all the aspects of this trial were not probably controlled. And it was, I think this is an important sentence because it tell us how to work in the future. And after that, and I think these trials today has moved to this perspective. So I will end nearly my talk after that. Just this slide to show you that this is in 2012, and definite and probable stent thrombosis is still a problem, you see. If you look at the bottom left, here, definite stent thrombosis, you can see that we are around 3% on the left here at the beginning. And even after the first 12 months, there are still separation of curves on the right. So the problem is between 0.3 and 0.6% every year for years and years. This just to show that many solutions has to be tried. With this is all variety of stents with clinical trial associated. And my conclusion is post-RAVEL, in fact, a lot of work on antithrombotic treatment was said already by Guy Hendricks. New stents, new drugs. I participated, for example, in actinomycin, was supposed to reduce the rate of restenosis. In fact, it was increasing. It was just stopped by a DSMB committee. Taxus was accused to promote cancer. Was the discussion polymer versus no, which kind of polymer. Biodegradable scaffold was also stopped for an increased rate of MACE. And now we are promoting synths and stent struts. And maybe to avoid to leave this factor of stent thrombosis years after years after years, this is suggested today that we can use drug-coated balloons. And I will end on the same remark as Dr. Nair. the lesion preparation is probably you have very new devices to do that today, and there has probably a good chance to help to stop this stent thrombosis epidemic. Thank you very much.